And welcome to the Dr. Bob Show. Are you snoring, and do you know that your snoring could harm your health? Recent literature, medical literature, says that snoring could be associated with your being overweight, with your having heart attacks, with your having type 2 diabetes, with you having vascular disease, all because of snoring. We'll be spending most of our show talking about snoring and how it harms your health and what we can do about it. My guest is Dr. Chris Nolte. He's a board-certified sleep specialist and also fellowship-trained sleep specialist. He'll be answering our questions. Hello, I'm Dr. Robert Overholt, and I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be explaining what does it mean by an enlarged heart? Could it be protecting you, or is it really dangerous and could be causing failure? And those dark circles under your eyes. Not enough sleep, or could it be allergies? We've got answers for you. You'll want to stay tuned. We're talking with Dr. Chris Nolte, board-certified sleep specialist, fellowship-trained in sleep. Chris, welcome to the Dr. Bob Show.
Thank you for having me.
We're going to be talking about obstructive sleep apnea, where people stop breathing during the night. And most people are aware that that is an illness. What's the typical appearance of somebody that has that?
I think the classic that people, particularly in this region of the country, remember is the UT football player, the big guy, big neck, big burly man. I think as our field has progressed, we're starting to realize that that isn't always the case. Women, thin people, kids can have sleep apnea as well.
So children, young children will have obstructive sleep apnea.
The peak age range is 2 to 8.
2 to 8. I tell people that there's 3 things that cause snoring. Bad nose, because they're having to pull, because they can't breathe, and a bad throat, because the throat is built like a snorer, and a bad belly, because the diaphragm doesn't move down to breathe. Is that correct?
That is exactly right.
And tell me about when people snore, is there an association with the degree of snoring, how loud the snoring is, how bad the snoring is, versus with obstructive sleep apnea?
For almost all patients, kids never read the textbooks, so they always follow a different set of rules. So children don't necessarily have to snore on a nightly basis and really loud. If they do, and you can hear them outside of the bedroom door, that certainly is suggestive. And certainly in adults, we always look for a history of habitual snoring, nightly snoring.
What does habitual snoring mean?
You know, a lot of people will say, well, you know, I snore every so often, maybe if I have a cold, but if you're talking about nightly snoring, that's what we are really concerned about.
I tell people the degree of snoring, if you wake up your neighbors or the ceiling starts falling down on you because you're snoring so loud. Is loudness of snoring, does that correlate with obstructive sleep apnea also?
It can. It's not all the time. So women don't often follow the same pattern. So you don't get a strong history sometimes of a lot of loud snoring. Sometimes there's an observation about unusual patterns of breathing. Maybe they just seem to pause or stop, but they're really struggling to breathe or snoring loudly.
When people have sleep apnea and they have the apnea part where they're not breathing, do they always wake up with a jerk?
Well, you often will get this. Sometimes the bed partner becomes concerned and reaches over to say, well, they don't see a whole lot of movement. Yeah, as soon as they touch, there's a resumption of normal breathing. But what we really like to see is that sort of classic sort of snort arousal. And I think that is an important history to get because that relates to how sleep apnea long-term becomes bad for you.
As you've seen a lot of people with obstructive sleep apnea, how many times an hour will they wake up? I think sometimes this just amazes me. An hour now.
Well,
60 minutes.
Yeah, exactly right. So when we observe them, we can see them wake a couple times a minute. Now, the typical sleep apnea patient is largely unaware. The reason they're coming in to see me is because their bed partner, their family member, their child, their physician has seen them struggle to breathe at night, complains about their breathing at night. Now, they may not feel great. They may not sleep well or be sleepy throughout the day. Largely, they're unaware of the breathing problems. Rarely you'll get a sensation where they wake, maybe their heart's racing a little bit, maybe they're hot and sweaty, like, maybe I'm dreaming something funny.
Yeah.
They get up, go to the bathroom and come back, but they're largely unaware of their breathing issues.
And when people are snoring and having obstructive sleep apnea, how many times an hour before you say, hey, this is bad enough, we got to do something about it?
Yeah, so we're all allowed to have a little bit. We think if you have 5 of these apnea events or less per hour, that's normal.
That's normal.
That's right. So we use the frequency of the apnea to gauge severity. Well, how bad is it? Is it mild or moderate, severe? That's based on frequency generally.
So how does this obstructive sleep apnea, how does it cause problems like high blood pressure, obesity, diabetes? Let's go into those individually.
You know, when you fall asleep and your muscles relax, your throat muscles relax too, and the throat can collapse, almost like a flat tire. I always will tell my patients, it's that fight or flight system that we're engaged with. When you turn the corner and see the attacker or the lion, your body is designed to give you that surge of adrenaline, to get your heart pumping, to get you, either going to fight or flee. That's the same system that engages when you don't breathe normally at nighttime. So if you look at the amount of adrenaline in the system of someone with untreated sleep apnea, day and night, even though this is a sleep-related problem, the levels are very high, and that starts to translate into higher blood pressures throughout the day, heart rhythm problems, increases in heart attack and stroke long term.
Is there a correlation with obesity? Does obstructive sleep apnea cause obesity and type 2 diabetes, or is it the other way around, or we're still learning?
They have teased this apart many different ways, and believe it or not, obesity, the severity of the obesity, we use something in the clinic called the body mass index, or the BMI, and you can start to grade someone's obesity into whether or not they're mild or moderate or severe. It's about as good as all of our screening questionnaires and all the things that we use to determine whether or not someone's at risk for apnea. If your body mass index is over 35, your rate of sleep apnea is about 90%, really, really high.
Wow, that's another important reason to get our weight normal. Tell me, how is the diagnosis made? What's a sleep study, and how are they done?
Well, this is a changing time in sleep. So sleep tests are done sometimes at home, sometimes in a more supervised environment. What we're looking at is the frequency of apnea events per hour. Traditionally, what we do is observe the sleep stages. So we're looking at dreaming and non-dreaming and light sleep and deep sleep and getting more detail about what happens to that patient throughout the night.
Can you figure that out with a home apparatus?
The typical home sleep study, even though it's called a sleep study, does not monitor any sleep whatsoever. It's really more of a breathing analysis. So that's important, because if we suspect that someone is at a really high risk for sleep apnea based on their history, and they come back to us with a sleep study, a home sleep study that is negative, normal, we don't stop there. We repeat the home sleep study several times, and sometimes we bring them back into a more supervised environment where we can monitor the stages of sleep.
When you have a supervised environment, you put an EEG, electroencephalogram, measure brain waves, as well as how many of these events they have. So it's more sophisticated, it's better.
And certainly more detailed, and the detail becomes very important when you're looking at treatment options, and you're looking at people who do not fit that classic poster child, football player type of patient. So women in particular will have an apnea that is mild, maybe moderate overall, but when they dream, it gets very, very bad.
When you make the diagnosis, when the diagnosis is established, do you have to have a routine CPAP machine, or are there some devices that you can put on?
So when I see the patients in the clinic, we have this discussion about what types of treatments are really amenable to their severity type. It really depends on how bad the apnea is.
We're talking with Dr. Dennis Bailey, past president of the American Academy of Dental Sleep Medicine. Dr. Bailey, welcome to the Dr. Bob Show.
Thank you, it's my pleasure.
And thank you for coming. Now, what should the dentist look for that would tip him off for obstructive sleep apnea?
Well, one of the things is tongue position. How far back into the oral airway does the tongue go? One is an elongated soft palate or uvula. Another might be what's called scalloping, like little ridges against the sides of the tongue. Coating on the back of the tongue, which could indicate that there's a breathing disorder. And then, of course, dryness in the mouth, where the patient may not have adequate lubrication.
So all of these things will tip the dentist off that a patient may be having obstructive sleep apnea. What should the dentist do to solve that solution? Are there dental appliances that work?
There are appliances called oral appliances, which are really lower jaw, we call them mandibular repositioners, which open the bite or open the jaw up and bring it forward to increase the tongue space and put tension on the musculature that supports the tongue and the airway to sort of tense it like a guitar string. And so what that does is it helps to support the airway during sleep when it's most likely to collapse due to the relaxation that occurs with sleep.
Are these dental appliances, are they effective?
They can be very effective. Oral appliances, unlike CPAP, which has been the gold standard for the treatment, take some time for patients to get used to and take some time to really see the results. But they can be quite effective in the 80% plus range.
And does the dentist manage the patient along with the sleep specialist, or do they take over the case?
This is a unique area because it's a or bidirectional relationship between the physician and dentist, co-managing the patient to get the patient to an optimum state of sleep so that the patient can go back and be retested to determine that the oral appliance has actually provided the effective outcome they've been looking for.
So what I'm hearing is, and thank you so much for coming to the Dr. Bob Show, when you see your dentist, he may find something that leads you to sleep medicine.
Absolutely. The dentist can be a conduit for understanding not only that there's a sleep breathing disorder or sleep apnea, maybe some snoring, but also can help with then solving the health-related consequences of this very tragic disorder.
I've just had a CPAP machine on. This was so easy. This is called a nasal pillow. We'll talk about it later. I didn't know the camera was coming on. Let's talk about those dental appliances. How do they work? If somebody has a breathing problem with the throat, what does a dental appliance do?
The most common type that's used has the patient sleep with their jaw held forward. So they're called jaw advancement or mandibular advancement appliances. These are made by dentists, adjusted by dentists. The question always is, well, how far forward does the jaw have to go to solve the problem? And that's where the sleep physician works with the dentist.
Have you ever seen it work like it did on the field report?
It's a great option for people with mild to even moderate severity sleep apnea. I have a lot of patients that use a hybrid approach. They might have a CPAP at home, but they're active, they camp, they travel a lot, they don't want to bring the CPAP with them, and the oral appliance is a perfect adjunctive treatment to the CPAP.
Now, I have some friends of mine that have the regular CPAP machine, and they wouldn't go anywhere without it. It's changed their life. They would not go without it, but they might be able, some people, to go on a trip with a dental appliance so they don't have to have the... How big are these CPAP machines that you have?
They have gotten increasingly smaller and smaller and quieter. The machines themselves are not really the problem, and they are almost silent. They sit on the bedside. They're quite small. They even make travel size ones now. I think most people's, if they have any apprehension about apnea and treatment, it's about the mask. They visualize this enormous thing on their face, and they don't even want to go down the road of getting diagnosed, even though they might appreciate that that's bad for their health, because they're fearful of having to sleep with something gigantic on their face.
Now tell me basically how this works. This has two little things that fit in your nose, and when you fit them in the nose, you put it around your ear, and then this hooks up to the machine?
Exactly right. So there's a
blows
hose.
air in?
Exactly right. So if you think of sleep apnea, almost like getting a flat tire, the upper airway just collapses just like the flat tire in your car. And what do? You take your car to the gas station and hook it up to that air compressor.
Yeah.
That's all the CPAP is doing. It's using regular, good old-fashioned room air under pressure to keep the upper throat open.
Now, if I'm laying down like this, that means I can turn over this way, and I can turn over this way, the machine still works?
Exactly right.
I can sleep on my side?
You can sleep on, in fact, we prefer that people sleep on their side.
Well, this seems too simple. Why would you want to wear a mask if you could wear this?
Exactly right. Well, it depends sometimes on how much nasal congestion and allergy and mouth breathing people do, how much pressure is required to fix their sleep apnea.
Tell me about what you mean by how much pressure.
So again, if you go back to our analogy of the flat tire, some people just need a little bit more air pressure to keep their throat from collapsing at nighttime.
So it pushes here in the back on the inside of the throat, keep it out, and so you have to know what pressure it is. That
Exactly right.
Sounds pretty scientific.
So part of what we do with the sleep test is try to make that determination. How much air pressure does the patient need while they're dreaming, not dreaming, on their back, on their side? And if we have it set the right way, that person who is carrying on, snoring, snorting, choking is virtually silent over there.
Oh, and that's absolutely fabulous. Tell me some stories about some people that have put on a CPAP, they've got the right pressure, and they stop snoring. What do you hear? You used a word like a game
changer.
Game changer.
So it's a very selfish kind of medicine to practice, because every week I hear something from patients saying that this has changed their life. You know, we're not very good monitors of our own function. We live with a lot of sleepiness and we power through. And when you fix that, they don't even realize how sleepy they were until the problem is solved.
I see a lot of people that are pretty sleepy, and sort of their head nods when it shouldn't. Is that somebody that might consider, hey, are you snoring? Hey, do you have sleep apnea? Is that why you're tired a lot?
And I think what we're seeing is a different in where the patients are coming from. I think the medical community is actually a little bit more attentive to this issue. A lot of times when you go into your doctor, they don't ask about sleep, they don't ask about snoring unless you bring it up yourself. But if your primary doctor is worried about your high blood pressure or your blood sugar level, they're starting to ask a little bit more about your sleep at nighttime, because the link between those conditions and sleep apnea is so tight.
So if I went to my doctor and he says, you've got high blood pressure, take this medicine, I come back, I've still got a little high blood pressure, why would he ask me about sleep right then? Because?
As you start to add medicine, it's amazing to me. If you're on 3 or more blood pressure pills, the rate of sleep apnea is almost 90%.
Whoa, 90%?
Very, very high, and that's because of that adrenaline that's coursing through the system,
Yeah.
because you're basically struggling to breathe every night. So if we can offload all of that guard duty function onto a CPAP, dental device, so that your brain doesn't have to be on guard duty all night long, you breathe normally, oxygen levels normal, adrenaline levels start to calm down a little bit, the patient wakes up feeling a little bit more like their old selves, a little bit more energetic throughout the day.
Why would a cardiologist, a heart specialist, want somebody to be sure that they had a sleep study? What makes them worry about their patients dying at nighttime?
I always think that any patient that crosses a cardiologist threshold should be asked about their sleep, just because the links between all of those conditions that they deal with, whether it be high blood pressure or heart attacks or heart failure or heart rhythm problems like atrial fibrillation, the link between that and the struggles to breathe at night, the fluctuations or changes in oxygen level that the body experiences because the breathing is abnormal is so tight. The cardiologists have been struggling so much with controlling those symptoms during the day that they're starting to pay attention to the research that shows that what goes on at nighttime is just as important.
So if somebody has obstructive sleep apnea and they don't get enough oxygen, the heart doesn't get enough oxygen for its muscles, so it gets irregular, high blood pressure goes up, the adrenaline. That's fascinating.
Yeah, the body, the brain, and all these other organs, their demand for oxygen doesn't go away.
Now,
so as the supply starts to go away, the workload on the heart goes way up.
it's pretty easy. Now, if I put this on behind my ear and get it fit, put this in, then you regulate the pressure and it throws air down the back without making a lot of noise.
Silent, almost silent.
That's absolutely amazing.
Yeah, one of the things, what I spend a lot of time on with my patients is really stepping back from all of what we do and trying to address what their anxieties are. And I think a lot of people's misconceptions are based on old technology. And the field of sleep medicine has really progressed quite a bit, not only in CPAP, but in dental devices and other kinds of treatment options.
One other thing that I wanted you to mention to me, and that is the follow-up, how important the follow-up is.
Yeah. So this is the old pendulum swing. What we used to do was give patients a CPAP machine and say, call us if you need us. And just the other day, I saw a patient that way. 10 years ago got a CPAP machine, an old clunker, and they couldn't use it, they struggled. Nowadays, we don't do that. We understand that there are so many different treatment options available that this requires a little bit of counseling, a little bit of support, that we see patients a lot more often now.
Chris Nolte, I can't tell you how much I've learned this evening about really the importance of a CPAP and how easy it can be for the patient. Don't have that fear is really what we're saying. Wonderful show. Now you're going to want to stay tuned. We'll be talking about enlarged heart. Could it be good for you or bad for you? And those dark circles under your eyes, is it because not enough sleep, or could it be allergies? I want to thank Dr. Chris Nolte. Wonderful discussion on sleep apnea and what we can do with different apparatuses to be able to breathe better and improve our health. Now for questions from you, the viewer, that I think will be important to your health. Dr. Bob, could you explain an enlarged heart? Well, it's pretty easy, but can be very, very complicated in its discussion. The heart is a muscle. It squeezes out blood. It does a fabulous job. If the heart is pushing out blood against resistance, then it's like muscles. It gets stronger and it gets bigger. That could actually enlarge the heart a little bit. It would actually be, for a little bit, a stronger heart. But as time went on, that heart would get tired and it would get weak and it would get flabby. Now, another part of an enlarged heart would be if somebody had what we call a cardiomyopathy. That means heart muscle problem. So there can be something go wrong with the heart muscle that makes it thin out. Part of the big pump is maybe the muscle is that thick. Well, it gets to be about that thick by getting larger, and it stretches out that muscle. And that muscle just doesn't pump blood out good. What can cause that? Well, too much alcohol. Alcoholic cardiomyopathy can be that. Some people get a viral infection that affects the heart. Some people have a toxic thyroid that can make the heart get enlarged. Some people have coronary artery disease and the heart is not getting enough nourishment and it gets big that way. In all those conditions, usually people end up going into heart failure. The heart is not pumping out enough blood, and so we begin to retain fluid, get short of breath, wake up in the middle of the night short of breath. If you're short of breath and you're having heart problems, irregular rhythms, and you must see your doctor. If he finds an enlarged heart, he will know what to do. Question number 2 from you, the viewer, Dr. Bob, why do I have dark circles under my eyes, or why do people get dark circles under their eyes? 2 or 3 things. Number 1, sometimes when people don't have enough sleep, we get puffy eyes and we get dark circles under our eyes and gets puffy and the eyelid falls down. It's just not enough sleep, especially not enough sleep as we get older because the skin is very thin below the eye. Now, the other thing that can happen, if you get a congested nose, the blood vessels that are in this way will try and drain to the nose where they will then eventually drain into the heart. If that happens, a stuffy nose can keep the vessels from draining, and when the vessels don't drain well enough, then we get puffy eyes or dark circles under their eyes. Now, when people have allergic faces, that means there's a certain description of the face in people that have allergies. Number 1, they push up their nose like this all the time. We call this the allergic salute. They'll get a little horizontal crease right in the nose. That's because they're pushing up the nose like this. If you can't breathe through the nose, you open your mouth. And when you open your mouth, your lips get dry when you're breathing through your mouth. And so the people are tongue thrusters because they're always wetting their lips. And they'll do that frequently. And it pushes out the teeth. And we get an overbite and widening of the front 2 incisors, front 2 teeth. We call that diaesthesis. We call it an overbite. The jaw falls back. We call that micrognathia. So there are certain appearances of the face that are very, very typical of people that have underlying allergies. If you've got a stuffy nose from a crooked nose, or you got a stuffy nose from allergy and your mouth breathing all the time and your eyes are puffy, and you wake up in the morning, your eyes are puffy and you've got dark circles under your eyes. There's also, when the eyes are puffy, you get little horizontal creases on your eyes. We call those Denny's lines. And so there are characteristics of the face that can be abnormal just because of underlying allergies or passed down from mom and dad. Now, that's all of the time that we have for this show. I hope you've enjoyed it as much as I have. Remember, if you've got sleep problems and you have sleep apnea, there are simple things that you can do. 4 things we like on the Dr. Bob Show is, number 1, exercise. If I had to pick one thing that we could really do, it would probably be exercise to maintain better health. It'll help keep our body weight the way we want. It'll get rid of sodium when we perspire. That will bring down our blood pressure some 10 points. It'll take away stress. It'll put out chemicals from the brain that give us a runner's high or a happy feeling if we just exercise. So exercise is so important. And eating properly. Don't diet, just eat properly. Look at your plate. Get a smaller plate. Eat smaller portions. Eat 6 meals a day. But it may mean a 1/4 of a sandwich, or it may mean a 1/2 of a little protein candy bar, or it may mean an apple, or it may mean a banana. Stay away from salad bars. They have too much bad things in them. 8 hours of sleep. Well, you know how important sleep is. If you get 8 hours of sleep and good sleep and restful sleep, then boy, you'll feel better and you'll just be able to tear up the world. So there's nothing like a good 8 hours sleep. And most of all, what is it we like in the Dr. Bob Show? It's that laughter in your life. Laugh a lot, giggle a lot, and you'll stay healthy.